Okay, imagine this. The heart's doing its thing, beat, 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 but suddenly the top part, the atria, just goes quiet electrically.
Yeah, like the conductor suddenly drops their hands for just one section of the orchestra. It's a bit weird.
And it makes you wonder, right? What's
Ooh.
going on? Is it just a quick blip, something temporary reacting to, I don't know, something else in the body?
Or is it maybe a sign of something more fundamental, a longer-term issue actually in the heart muscle?
Exactly. So today we're diving into this condition called atrial standstill. We've got this detailed medical text, and our plan is basically to pull out the key stuff, the interesting bits, to give you a really clear picture of what this is all about.
Right. And, maybe you've heard the term somewhere, or maybe you're just fascinated by how the body works and sometimes how it trips up a bit.
We're going to try and keep it clear, avoid drowning in jargon.
Definitely. So normally you've got this little pacemaker, the sinoatrial node, up in the atria, starting the whole electrical cascade.
And that shows up as the P wave on an ECG, right? That first little bump.
Precisely. Atrial standstill. That's when those P waves just vanish. They're gone.
Okay, so the first really big takeaway from our source seems to be that this isn't just one thing. There are two main types.
Yes, absolutely. Crucial distinction. You've got the temporary or non-persistent kind and then the persistent kind.
And understanding that difference is, well, it's key to the whole thing, why it happens, what it looks like, how you deal with it.
Couldn't agree more. So should we start with the temporary one, the non-persistent type?
Makes sense. So our source says this often pops up because of, like, a temporary problem elsewhere.
Yeah, often it's triggered by something reversible. A big one is high potassium levels in the blood that's hyperkalemia.
Ah, electrolytes again.
Always messing things up, aren't they? Or sometimes certain medications can do it too, but hyperkalemia is like the classic cause mentioned.
Okay, so high potassium. What does the ECG look like then during this temporary standstill?
Well, the heart rate itself can be kind of variable, normal, maybe a bit slow. The rhythm can actually be irregular, which is interesting.
Irregular, even though the atria is quiet.
Yeah, we'll get to why in a sec, but a really key finding involves the QRS complexes, the big spikes showing the ventricles working.
Okay.
As potassium climbs, those QRS complexes tend to get wider, and if it gets really high, like over 10 milliQL, they can look really bizarre, almost like a smooth sine wave.
Wow. Okay. And anything else specific?
Yes, something quite telling. If you give atropine, a drug that usually speeds up the heart,
Yeah.
in this type, the temporary kind, the heart rate might actually tick up a bit. It suggests something is still, potentially responsive.
So hang on. Even though the P waves are gone, you're saying the heart's natural pacemaker, the SA node, might still be firing in these temporary cases.
That's exactly what the text implies. It's not that the node is dead, necessarily. It's more like the signal it sends out isn't getting through to activate the actual atrial muscle cells.
Ah, like the spark plug is working,
Mm-hmm.
but the fuel isn't igniting properly in the atria.
Good analogy. So the impulse might bypass the atria and go straight to the ventricles. This is what's called a sinoventricular rhythm.
Sinoventricular, okay. And that irregularity you mentioned earlier.
That might actually be the underlying sinus node still doing its thing, maybe speeding up and slowing down slightly with breathing that's normal sinus arrhythmia. The node is firing, just not triggering the atria.
Got it. Okay, so what kind of medical conditions actually cause this high potassium, this hyperkalemia, that leads to temporary atrial standstill?
The source lists a few important ones. Hypoadrenocorticism Addison's disease is a big one. The adrenal glands aren't working right.
Okay.
Also, anything causing a urinary tract obstruction, like a blocked bladder, or even a rupture. Basically, if the body can't pee out potassium effectively.
Makes sense. Waste builds up.
Exactly. And severe kidney failure, especially the kind where very little or no urine is being produced, oliguric or anuric renal failure. Same problem, potassium builds up.
Right. So if a vet suspects this temporary form, based on the ECG and maybe the animal's history, how do they confirm it and figure out the cause?
Well, blood tests are key. Finding that high potassium level is obviously number one.
Obviously.
But the text also mentions looking at sodium. Low sodium, along with the high potassium. Specifically, a sodium to potassium ratio less than 27 can be a big clue pointing towards hypoadrenocorticism.
Okay, that ratio is useful.
Yeah. And if it's a kidney or urinary issue, you'll likely see other signs in the blood work, like azotemia, that's the buildup of waste products, and maybe high phosphate levels.
And if Addison's is really on the table.
Then you'd typically do an ECTH stimulation test. That's the standard way to diagnose it.
Okay, so let's say you figured out it is hyperkalemia causing this temporary standstill. How do you treat it?
The absolute #1 priority is treating whatever caused the high potassium. You have to fix the root problem, the kidney failure, the Addison's, the urinary blockage.
Right, makes sense. Treat the cause.
But immediately, you also need to manage the dangerous effects of the high potassium itself. Aggressive 5E fluids are crucial, specifically 0.9% saline plain salt water, basically. It helps dilute the potassium and rehydrate.
Call your fluids. What else?
Depending on severity, you might use sodium bicarbonate or a combination of insulin and dextrose. Insulin helps drive potassium back into the cells.
Ah, interesting mechanism.
And calcium gluconate is really important. It doesn't lower the potassium, but it directly protects the heart muscle from the dangerous electrical effects of the high potassium. It stabilizes things quickly.
So it buys you time while the other treatments work.
Exactly. And crucially, you absolutely avoid any fluids that contain potassium. That would just make things worse.
Sounds like a multi-pronged attack. So what's the general outlook, the prognosis for this temporary kind?
It's actually usually excellent if you can successfully identify and correct the underlying cause of the hyperkalemia. Get the potassium back to normal, and the heart's electrical activity should follow suit.
That's good news. Really reassuring. Okay, so that's the temporary picture. Now, let's shift gears to persistent atrial standstill. This sounds less temporary.
Yeah, definitely. This is generally a more chronic issue. Our source links it to something called atrial muscular dystrophy,
Muscular dystrophy, but in the heart.
specifically affecting the atrial muscle, yes. And interestingly, the text notes it often involves skeletal muscle, too.
Huh. So a problem with muscle tissue that affects both the heart's upper chambers and, say, the limb muscles.
Seems like it. It raises questions about, shared genetic factors or developmental pathways.
Fascinating. So what does the ECG look like in this persistent form? How's it different?
Well, again, the P waves are absent, just
Yeah.
gone consistently.
Okay, it's the same as before there.
Right. But the heart rate is usually quite slow bradycardic, often under 60 beats per minute, and the rhythm tends to be very regular. The QRS complexes, the ventricular beats, generally look normal in shape.
Okay, slow and steady, but no P waves. What about the atropine test?
Ah, that's the key difference. In persistent atrial standstill, you give atropine, and nothing really happens to the heart rate. It doesn't increase significantly.
So that lack of response to atropine is a major clue that this is the persistent type, not the temporary hyperkalemic type.
Exactly. It tells you the problem isn't just a temporary functional block that atropine might overcome. It's something more intrinsic to the atrial tissue or its ability to respond.
So we're talking about a structural or maybe a deep functional problem within the atrial muscle itself, not just an electrolyte imbalance floating around.
Precisely. And the source mentions breed predispositions. English Springer Spaniels seem to be the poster child for this in dogs.
Really? Springers?
Yeah, it's noted as the most common breed, and it often affects younger animals, which is kind of sad.
Any other links?
Well, it also mentions that animals with hypodunocorticism, Addison's disease again, can sometimes develop this persistent form, usually young to middle-aged.
Wait, so Addison's can cause both temporary via hyperkalemia and potentially persistent atrial standstill.
It seems that way, though the mechanism for the persistent form in Addison's might be different, perhaps related to chronic hormonal effects or maybe inflammation. It's complex.
Okay. What symptoms might you see in an animal with this persistent condition?
Lethargy is common, just low energy. And syncope, which is fainting or collapsing, often due to the very slow heart rate not delivering enough oxygen to the brain.
Fainting. Okay. That's serious.
It can be. Some might even develop signs of congestive heart failure, or CHF, because the heart's overall function is compromised over time.
And on a physical exam.
You typically find that slow heart rate, the bradycardia. And sometimes, especially in those predisposed breeds like Springers, you might actually see visible muscle wasting, particularly around the shoulders and forelimb.
Wow, the skeletal muscle link showing up physically. Does it connect to other heart diseases too?
The source mentions a possible association, yeah. For instance, in cats with certain types of cardiomyopathy where the atria become really stretched out and enlarged, you might also see atrial standstill develop.
So, diagnosing this persistent form. ECG is obviously crucial, again, for the absent P waves and slow rate. What else?
An echocardiogram, an ultrasound of the heart, is important. It might show the heart chambers are enlarged, cardiomegaly, and maybe that the heart muscle isn't contracting as strongly.
Checking the structure and function.
Exactly. Sometimes electromyography, EMG, which tests muscle electrical activity, might be done, especially if skeletal muscle wasting is seen. And a skeletal muscle biopsy can actually be diagnostic in some cases, confirming the underlying myopathy.
And if you were to look directly at the heart tissue pathologically, what would you find?
Often the atria are severely enlarged, dilated, and the walls are thin. Usually affects both the left and right atrium.
Thin and stretched out.
Yeah.
Yeah.
And microscopically, you'd see things like fibrosis, scarring, fibroelastosis, which is an increase in fibrous and elastic tissue, signs of chronic inflammation, and sometimes even fatty infiltration within the atrial walls. It really points to diseased muscle tissue.
Okay, that paints a clear picture of why it's persistent. So how do you treat this? You can't just fix the potassium here.
No, you can't. Since the main problem causing symptoms like fainting is usually the dangerously slow heart rate, the primary treatment is a permanent ventricular pacemaker.
A pacemaker, like in humans.
Exactly. It artificially sets the pace for the ventricles, ensuring the heart beats fast enough to maintain blood pressure and perfusion.
Does that fix everything?
It fixes the slow heart rate and usually stops the fainting spells, which is huge. But if the animal has also developed congestive heart failure because of the underlying muscle disease and chamber enlargement,
Then you need other meds.
right, you might need diuretics to manage fluid buildup, and ACE inhibitors to help the heart work more efficiently. And activity restriction is usually recommended for those with CHF or ongoing weakness.
So what's the prognosis with persistent atrial standstill, even with a pacemaker?
Well, the pacemaker definitely improves quality of life and survival by managing the bradycardia, but the underlying atrial muscle disease and potentially skeletal muscle disease is still there. It's progressive.
So signs might linger or worsen over time.
Yeah, signs of heart failure, weakness, lethargy, they might persist or progress despite the pacemaker keeping the rate up. The pacemaker fixes the rhythm, not the muscle itself.
Okay, so let's just quickly recap the main differences then. Temporary versus persistent.
Okay, temporary. Usually triggered by high potassium, hyperkalemia. ECG shows absent P waves, maybe wide QRS, but crucially, the heart rate might respond to atropine. Treat the underlying cause, prognosis often excellent.
Got it. And persistent.
Persistent. Due to actual disease of the atrial muscle, a muscular dystrophy often involves skeletal muscle too. ECG shows absent P waves, slow, regular rate, and no response to atropine. Treatment is usually a pacemaker. Prognosis is more guarded because of the underlying progressive muscle disease.
Perfect. That distinction is so critical.
It really is. You know, it's such a good illustration of how the same basic sign, no P waves on an ECG, can mean two vastly different things are going on under the hood.
Requires totally different diagnostic paths and treatments. It highlights why just looking at one piece of data isn't enough.
Absolutely. You need the whole picture.
So, wrapping this up, we've explored atrial standstill, the silence in the heart's upper chambers on the ECG. And the big message is, it's not monolithic.
Definitely not. You've got that temporary version, often potassium-driven, which can be fixed if you address the cause.
And then the persistent type, rooted in muscle disease, needing management like a pacemaker, but with that underlying condition still present.
And thinking about those really different causes for what looks initially similar, it kind of makes you wonder, doesn't it, what other conditions out there seem alike on the surface, but actually have completely different things going on underneath, requiring totally different approaches once you dig a bit deeper. It's a good reminder to always question and look beyond the obvious.
That is a great point to chew on. If this deep dive got you thinking, maybe you'd want to look more into reading ECGs or the whole world of electrolyte imbalances, or even delve into cardiomyopathies. There's always more to learn.
Indeed there is. Well, thanks for joining us on this exploration of atrial standstill.
Yeah, thanks for tuning in.